Good afternoon. My name's Mark Smith and I'm a clinical lead with Depoe's information program based in Hamilton in New Zealand, and I've been in this role for the last 8 years, and I'm going to be talking today about the use of routine outcome measures, its collection and use in the New Zealand mental health and addiction setting. New Zealand has adopted a nationally led approach to the use of routine outcome measures that's relied on 3 key components. There's the routine outcome measures themselves, and I'll say more about those in a moment. There's a national data set which collects activity and outcomes information by clinicians, proved very useful and informative. And we've also developed a key performance indicator framework for New Zealand services. So these are the key kind of nationally led initiatives that have informed the routine use of outcome measures. New Zealand has also adopted a phased approach to the use of routine outcome measures based on 5 key areas. The 5 areas are clinical symptoms, and the HONOS family of measures has been adopted for that purpose. There's alcohol and drugs, and we've very bravely developed our own measure here in New Zealand, which we're calling the ADOM, the Alcohol and Drug Outcome Measure. There's a Maori measure, which we've developed, which hasn't yet been adopted nationally. There's a self-rated area, and we haven't yet decided what that will be. And there's a functioning area, and we haven't decided on that either. So it's a phased approach, starting with the HONOS family, and then bringing in the ADOM July 1st, 2015. And New Zealand has very strongly emphasised the routine use of outcome measures. Now let me say a bit more about that. You can at one level see the use of outcome measures as a research activity. And New Zealand has very strongly wanted to move away from that idea and emphasise that it's something that clinicians should do as part of their routine clinical practice, not as something extra. And this has been strongly emphasised in all of our publications and our training materials, that it's a routine part of clinical practice. New Zealand strives to achieve ROM usefulness by ensuring that ROMs are part of workforce development, and New Zealand has emphasised workforce development as a key component of the rollout of outcome measures over the last 10 years, really, effectively, ensuring that the sector has the capability and capacity to actually collect and use outcome measures. Secondly, New Zealand has adopted a train-the-trainer approach to ensuring that the sector has the necessary skills and understanding to collect and use outcome measures. And additional to that, every quarter we send out reports to the sector. These are aggregated reports based on their own outcomes information. And this has proved very enlightening, I think it's fair to say, and has been something of a catalyst in terms of ensuring that services want to collect their outcome measures. I should say, in terms of how we've ensured usefulness with routine outcome measures, that New Zealand has adopted this idea of different levels of information. And sometimes people in the sector think it's all about the ministry and all about the national collection, and it's not. There's really 4 identified levels of information. There is the national level, absolutely, no doubt about that. There's also the service level, the team level, and the clinician service user level. And each of these levels can find particular uses for outcome measures, and they're not mutually exclusive in that sense. Routine outcome measures have a number of uses which clinicians and service users can take full advantage of. In the case of service users in New Zealand, there is little doubt that if their outcome measure scores are being fed back to them, and that's a key caveat, if they're being fed back to them, then it's going to assist service users to set their own goals, to develop their own recovery plans, and to be able to develop meaningful therapeutic conversations with their clinicians. In other words, it's going to empower them. Many of the things that we value in terms of recovery-orientated services provide hope, empowerment, choices, things that are currently very much the philosophy of most jurisdictions around the world. In terms of clinicians, again, if they're actively collecting and using outcome measures, they're going to be able to use these measures to develop care plans, meaningful care plans that are based on real assessments. Additional to that, they're going to be able to have some sense of the severity of their caseload. And the severity of their caseload will tell them whether they're doing their core business as clinicians in a district health board. These are all kind of useful uses. Particularly in inpatient units, I should stress that discharge planning is a particularly helpful use of outcome measures. And obviously in inpatient units, people are there for less time than they are in the community. And so there is a greater emphasis on the discharge element than perhaps in a community setting. Routine outcome measures can be useful for teams as well as individual clinicians and service users. Now, I mentioned earlier that you can see information at 4 different levels: the national, the service, the team, and the individual clinician service user level. The team is an interesting level in terms of information, because the team can use both individual information for clinicians, service users, but it can also use aggregated information. And that makes it a potentially very powerful level of information, because it's the only level that uses both individual and team aggregated information. What are some of the uses that teams can make of outcome measure information? Well, one of the things that they can certainly do is start to use it in their review meetings. All teams have review meetings, usually every week or so, to review cases. Using outcome measures is a way of keeping focused and disciplined in terms of the team. It assists the team to know the severity. Again, are they doing their core business as a clinical team, seeing people who have particular clinical needs? It can help the team to have a common language in terms of the various professionals who are working in that team. And I guess, finally, it can help with performance accountability for the team. Are they actually succeeding in terms of their outcomes?